Thanks, Dr. McCarty, a pleasure. So we've just looked at 6 talks about rotator cuff tears, and I think this goes to speak to how difficult the treatment of rotator cuff tears are and how many different opinions we have. And with that, there's probably as many different and varied opinions about rehab after rotator cuff tear. So my disclosures remain the same. The biggest challenge with rotator cuff post-op rehab is balancing healing with time to function. So we know that we don't want people to get tight or lose their functional ability, but there's nothing worse than having a patient who can't function appropriately because they didn't have their rotator cuff repair heal, and maybe we went too fast. So we have to balance those things, and that starts with making sure we understand the considerations and the time frame to the development of the problem. So is it really a mechanical or chemical problem, or more likely both types of problem with things like poor vascularity, altered biology? Smoking has been talked about. If the problem is long-standing, then we have other impairments to deal with, such as decreased acromial-humeral distance, maybe some additional joint problems like osteoarthritis, scapular dyskinesis, and altered muscle activation. This time frame leads to increased stiffness of the tissue, which gives us concerns about long-term extensibility and functional flexibility for patients. But in addition to that, it also gives us problems with tissue quality. So Dr. Meyer talked so eloquently about the cuff insertion, and I think he hinted to and even said that when we have a cuff repair, it doesn't necessarily recreate the tendon in its original format. So we have different types of collagen, and with that, we have different types of concern about the healing, and so we have to respect that. So there's some primary factors that we use to choose the post-operative course we have following rotator cuff repair. We talked about age-related changes. We know that Boileau in 2005 told us that in 55-year-olds, 95% of them typically heal with a small rotator cuff tear. But 10 years later, only approximately 60% of those same people will have healing tissue. Fatty infiltration, tendon healing timeframes, the tendon's response to immobility and remobilization are all important characteristics to consider. And we know that failure really has some indicators to it. For functional outcomes, the increased time from tear to fixation, this acute with chronic, or chronic with acute tearing, or chronic tearing, increased age, as it's been talked about several times, and then decreased preoperative forward elevation, range of motion, and strength are strong indicators that our functional outcomes are in question. We know there are anatomic outcomes that of increased tear that have been associated with things like tear size, retraction, tissue quality, fatty degeneration, and then also other biceps pathology. But functional outcomes don't have to equal anatomic outcomes, especially if we're careful with the rehab process. There are other factors included in these things that we need to consider, not only the duration of the problem, but does the person have any mobility issues that we should pre-op or pre-rehabilitate before they go on to surgery? So if they have mobility problems where they would need a walker or a sliding board to transfer, it often helps to clear up those problems before they had surgery. Why they came to surgery: was it pain? Was it function? Was it a combination of both? Are there goals to become or go back to CrossFit activities, be a laborer, be a golfer? Or are there some more limited goals that the patient is willing to be happy with? So what is known is that clinical outcomes are widely reported to be good, and that's irrespective of some of the anatomic failure or anatomic issues that occur. 98% of the failures occur in the first 6 months. And as Dr. Schlegel said, we only have 25% tensile strength by 12 weeks. So size and recovery time do matter in planning the postoperative rehab. This is a table from the American Society of Shoulder and Elbow Therapists publication in 2013 that was provided in a JSES, looking at the pathway for rotator cuff rehab. And you'll notice that the pathway is really built on not only what we know about rotator cuff repair and all the things around rotator cuff repair, but also what we know about EMG activity of exercise. So you see phase 1, 1 to 6 weeks, and phase 2, 6 to 12 weeks, really isolate exercises that put decreased EMG activity through the repair site, so less than or equal to 15%. Also emphasized is decreased ultimate loading and decreased cyclic loading. If we look to the next 2 phases, 8 to 16 and 12 to 20 weeks, we really escalate the EMG activity from 16 to approximately 30%, and then 30 to 49%. You see in that 8 to 16 week time frame is the first time frame that any activity in part of the rotator cuff is active or resistive. And then in the 12 to 20 week period, we start with some elastic resistance so that we can progress people that are appropriate into phase 4, which is greater than or equal to 50% strengthening. This appropriateness is based on tissue repair, tissue quality, the report from the surgeon, patient preference, and patient goals. If they're not returning to high-level function, then we minimize the stress that we put through that tissue. So the summary of that is for the first 4 to 6 weeks, we're careful to load slowly across the tendon, and we control load by loading or limiting the range of motion, limiting the speed of motion, and making sure we're respecting the inflammatory and healing response. We gradually introduce stress during the maturation period to help the tissue mature. And we don't use pain as our guide because we know that isn't always the best predictor of injury. Often patients show increased inflammatory response and injury prior to experiencing pain. So if you look at the pathway for the smaller to larger repairs, you'll see that in phase 1, the larger repairs are delayed by 3 weeks, but essentially go through the same process. In phase 2, they're delayed by 2 weeks, but essentially, again, go through the same process. In phase 3, it's a 3-week delay again. So the implications or the important tenets are education, so the patient understands expectations and what they should do, protecting range of motion, and slowly, progressively loading to increase function. So the rehab plan should match the surgery and the patient's available range of motion. Risk factors for stiffness, calcific tendonitis, adhesive capsulitis, and partial repair. Additional range of motion exercise is effective at the end parts of rehab in order to restore the range of motion. We know that delaying stress to the tissue is important. If we do manual therapy, to make sure that we do it in areas where there's less stress on the tissue and we don't create gap formation. So in summary, controlled loading and return to activity are preceded by no heavy lifting for 4 to 6 months, and our progressions are listed here. The central question is, how do we load the repaired tissue and make sure we get the physiologic adaptations of the surrounding tissue without stressing the repair? Thank you.